being here today. You are a pelvic pain doctor. What exactly is a pelvic pain doctor?
So first off, thank you for having me. I think a pelvic pain doctor can really mean many things to many people because it's really a specialty that's kind of built on a niche. So for me, what that means is that I'm actually a GYN by training, and I did my residency actually at New York Presbyterian, Cornell up on the Upper East Side, and then I did my fellowship in the Department of Urology. And I stayed on to do a lot of work with patients who have interstitial cystitis, pelvic floor dysfunction. So for me, being a pelvic pain specialist really means being able to elucidate problems or issues with the entire pelvis that can occur. And I think that this is one of the biggest issues with medicine as a whole. So I think one of the problems that we have with medicine is that we're really good at treating systems, right? So you have like a GYN who's just treating that stuff, and a urologist that's just treating that, and then a physiatrist that's just treating muscles. And oftentimes patients can get lost in this shuffle because their symptoms can actually be a little bit urological. They can be a little gynecological. They can be related to sitting or walking, and they don't know where to turn. And with that sort of fragmented care, I think that patients often get lost. They often have unmet needs and unanswered questions. And so for me, being a pelvic pain specialist really means being able to holistically look at someone and evaluate all of these different areas.
And what are some of the things that you treat? What are some of the conditions, illnesses?
So some of the things that I treat are really what I would call comorbidities to endometriosis. So I fully like always say I'm not an endo specialist. I love working with endo specialists because I think they're amazing, but I'm also my specific focus is on other comorbidities that occur with endometriosis. So things like interstitial cystitis, things like pelvic floor dysfunction, things like vulvodynia or vestibulodynia, things like other vulvar dermatoses like lichen sclerosis, lichen planus. Oftentimes when we have all these bouts of inflammation that can kind of occur in different ways and can present themselves in different ways, you can also have alterations in the pH and recurrent infections, and those are also things that I treat.
So how if someone was to walk into your office, what would be some of the questions you would ask them? Because what we hear a lot is people get shy in front of a doctor. They
Mhm.
get overwhelmed, they get nervous, they don't know what to say, what not to say. What are some things that you recommend a patient come in and tell you, and how much should they tell you?
So I love this. So for me, even in my office, I make sure that my appointments with patients are almost over an hour because I don't think you can get through everything in that simple 15-minute time frame. So I always ask patients when they're coming to me because by the time they've gotten to my office, generally they've seen multiple other practitioners. And what I tell them is that I like to be their last stop. I like to be able to evaluate everything for them so that they're not kind of being tossed around or felt like they're not being heard. So I like patients to kind of write down their history for me before they even come in. It's something that's super important to me. I read it before they come in to just get a lay of the land. You know what I mean? When you finally get to this position where they're in my office, it's all about the nuances. I'm not trying to reinvent the wheel here. I'm trying to kind of do a little detective work. Like, what have we been missing? Where have we been going wrong? How do we kind of turn back and evaluate this issue so that you can actually see tangible change? So one thing that I always encourage every patient is write down your clinical history before you come in to see a doctor. Sometimes just writing it down, you almost notice a pattern. You're like, wait a minute, I didn't realize that I had that flare that occurred after that, whatever,
Mhm.
sex, walking around, whatever it was, because that can lead us to figuring out what's happening and to really coming up with a more accurate diagnosis and treatment plan.
When you talk about comorbidities and endometriosis, can you explain what some of those are? I know we did a generalized list, but can you kind of break down what those could look like in terms of symptoms?
Absolutely. So the first one, I guess I would say the biggest one, the one that is known as the evil twin of endo, is something called interstitial cystitis. And the reason that it's called the evil twin is because studies suggest that almost 70 to 80% of patients who have endometriosis also have interstitial cystitis or bladder pain syndrome. So that's exactly why certain patients can undergo procedures, surgery, have all these great treatment plans for their endo, but continue to be symptomatic. And oftentimes these symptoms are really related to the bladder. So symptoms of interstitial cystitis include things like frequency, what I call persistent urgency, which is the feeling of you always gotta go, the feeling of pain when the bladder fills, discomfort when the bladder fills. They can also have pain after they urinate. And oftentimes this can also alter based on their cycles. So in general, in patients who have interstitial cystitis, they can notice that their symptoms really what I call flare right before their periods and actually get better during. So this is a little bit different than endo pain, but it's something that's really key and specific to interstitial cystitis and almost unmasked after they're having their endo treated. Do you know what I mean?
Yeah.
So that's one thing. The other thing that we kind of touched on was something called pelvic floor dysfunction. So while the data on this isn't as clear as it is with the conjunction between interstitial cystitis and endometriosis, studies suggest that almost 90% of patients who have endo or IC actually have what's called pelvic floor dysfunction.
That does not surprise me.
And you think about why, right, Diana? You think about this, what happens when you're in pain? What's your like reflexive, exactly, body response to clench? So then what happens? The bladder contracts, the pelvic floor actually spasms, it doesn't release. So now you leave a little bit of urine in the bladder. So oftentimes a little bit of urine in the bladder is like a puddle of water outside. It's a great nidus for infection. So sometimes patients are noticing recurrent infections. Other times they're just noticing a lot of bladder-based symptoms, difficulty with frequency, urgency, feeling like they're not completely emptying, changes with like even having a lot of pain with like deep penetrative intercourse. So like these are all symptoms that, as you can see, can occur all together, and oftentimes it's hard to peel them apart. But that's another entity that's quite common that I see a lot of. One of the other ones, which I mentioned really quickly, is something called vulvodynia or vestibulodynia. So a certain subset of patients can have unexplained vaginal pain. Now, back in the day, we used to call this vulvodynia, but we kind of changed nomenclature because vulvodynia doesn't really mean anything. It's like saying inflammation. Okay, inflammation where? You know what I mean? So now we've broken that down into something that's known as vestibulodynia, essentially like figuring out where that actual pain is coming from in the vagina. So is it more localized? And then dividing it up into categories. So things like hormonally mediated, neuroproliferative, inflammatory. And if you can break down vulvodynia or vestibulodynia into these groups, you can actually accurately treat it and give patients essentially like a wonderful quality of life. And then other things that I see a lot of is like other vulvar dermatoses. So we don't realize that the tissue in the vagina and the vestibule is like the epidermis. It's like skin everywhere. And I always tell patients, you know, we're always good about our skincare and we buy all of these products and we make sure it's perfect. But when it comes to vaginal skincare, we're just kind of like, meh, you know, whatever, just gonna like
Shower. Right.
use whatever soap, you know, like, but that's important to look at too, because if you start to have any type of dermatologic issues that occur there, again, what's a reflexive response? To contract. Now, if you also have endo, can that increase your pain? So, you know, you got to divide all this stuff up, because if there's a combination of things going on, you're not going to see full relief until you address all of these other pain generators.
There's a lot to tackle. And I think you are right, because there is a division of specialties. And when somebody is going through endometriosis, not everything can be put under the endometriosis umbrella. So to have someone who takes a holistic approach, and also, like you said, I love how you use the word detective, because it takes patience to be good to your patients.
Absolutely.
And that doesn't always occur with every physician. And I applaud you for setting that setting that time aside, because it matters to the individual. Like, as you said, they've already been through the circus of seeing doctor after doctor, specialist after specialist, and they're coming to you for a reason. And the reason is they're not feeling well and they want a better quality of life. Thank you for explaining your profession, what you do every day, and hopefully giving insight to someone who might be sitting there going, I'm at my wit's end in pain. And now I know what to ask and who to look for in terms of the proper doctor for me.
Oh, thank you. That means so much.
I hope you'll come back.
Oh my God, I would love to. I feel like we could talk for hours, you and I, about so many different
Oh,
things.
there's a lot. Oh, there's a lot. And I think everyone watching feels the same way. We've only chipping
The
away.
surface.
Yes, there's a lot going on. But thank you again, and we will see you soon.
Thank you so much.